When my husband experienced chest pain, I knew he had to go to the ER at Fairview Park Hospital because it had an accredited chest pain center. Chest pain isn't like a broken arm or a high fever. They treat chest pain like the serious condition it is, and they treat it fast. And it was a good thing we knew the difference because my husband was in cardiac arrest.
Oh, I was fine.
Now he is.
Treat chest pain like chest pain. Choose the ER at Fairview Park Hospital.
Basically, the way I like to structure these is I'm going to give you just a very brief overview on COPD. We're not going to go into the other pulmonary disorders that people have to deal with, and then just open the floor up for any type of question you might have. I have a firm belief that there's no such thing as a stupid question, just a stupid answer. So having said that, let's talk about COPD. Basically, it's chronic obstructive pulmonary disease, and it's the people that have difficulty with breathing after years of smoking or years of occupational exposures such as dust, paint, chalk, things that we see a lot of in these smaller communities where factories are a big component of our workforce. There's two forms of COPD. There's the emphysema side, which causes actually destruction, and you see some barrel-chested people. And then you have the chronic bronchitis side, and that's the people that have difficulty with clearing their secretions, clearing their mucus, and they have that chronic cough. The impact of that is essentially when you smoke, smoking can cause one of two things. One, your entire airway is lined with little hairs. They're called cilia. And immediately after smoking a cigarette, you will see that these cilia, the hairs, start numbing up and stop working. Normally they push the mucus up out of your mouth. Once you start smoking, they basically anesthetize all of these cilia, kill some of the cilia, so long term you'll have more and more trouble clearing those secretions. COPD should not be taken lightly. It's the third cause of death in the United States. It's about roughly 120,000 patients a year get admitted. But knowing the mortality of it is very important. So that's basically the two breakdown of COPD, which is chronic bronchitis and emphysema. The cornerstone of treatment is stopping smoking. That's the number one thing that you have to do. Over time, over 6 to 8 weeks, the nicotine craving will go away, but also there will be some more motion of that cilia. You will see more improvement of airway clearance, improved ability to manage secretions. There are multiple therapies now, too, as we've gotten more and more advanced with medicine, including multiple types of inhalers, which I'm not going to go into detail with, but we can always do that when you see a doctor in the office. But what these inhalers tend to do is the goal is to improve symptomatology, so you are able to do more, but also to decrease what we call COPD exacerbations, where patients need steroids, antibiotics, things of that nature to get over an acute phase. Obviously, the medication side we can talk about more if a patient comes to see me or my partner, Dr. McCormick, but I also want to focus on the pulmonary rehab side of things. Since we were children, we were always told that exercise and diet, exercise and diet. And that's not something that we should forget as we get older. The one problem that I've always noticed in the setting of patients who have breathing difficulties, and that is patients have a tendency to come back and say, listen, I don't have any problems with my breathing, but what you've noticed is that they've stopped doing what they used to be able to do. All of a sudden, going up a flight of stairs is harder. All of a sudden, going to your mailbox is harder. They'll come and say to us, no, my breathing is fine, but that's because they didn't go to their mailbox anymore. So these are the things that we have to, our goal is to improve quality of life as well. And that's where a comprehensive program such as pulmonary rehab is of utmost essence. It's guided by our respiratory therapists and nurses. It's monitored throughout the whole time. And every week, the physicians are involved on seeing your progress. I have seen, since we opened this program in April, I've seen a dramatic difference in the patients that actually did take the initiative to join and work out here. Particularly one patient, I can't say any names, but this gentleman had been in and out of the hospital 5 times over the course of a year. He started pulmonary rehab. He hasn't been back to the hospital once since April. These are all the impact that mobility will make. It'll help you bring stuff up. It'll help you. In addition to that, as you get better and better in your exercise regimen, it also influences you not to want to smoke anymore, to have more concern for your breathing, your lungs, and your overall health. Along with that goes maintaining proper immunizations. As you develop COPD and get worsening lung disease, there's always the concern of the flu and pneumonias and how much of an impact that can make on your breathing when you don't have the reserve that a 19-year-old would. Therefore, I recommend to every patient get your flu shot, get your pneumonia shot every 5 years, and stay absolutely up to date with it. That's kind of COPD in a nutshell. I want to open up the floor to anybody who has any questions, and just fire away.
Since smoking is so important in the management of COPD, how about those e-cigarettes?
You know, that's becoming a question that I don't know has been researched enough. Here's the way I look at it, and obviously this is, I think, partially my own opinion, but I've seen varying articles on e-cigarettes right now. What I have found is that e-cigarettes have removed a large component of the additional chemicals that are in cigarettes, first. Second, it decreases the amount of consumption of cigarettes. People will smoke the e-cigarettes, but they're not smoking 2 packs a day that they used to. With the overall success rate of quitting smoking in America of about 40%, I find that to be a compromise as we make our way towards complete tobacco cessation. So if a patient comes to me and says, I've switched over from 2 packs a day to the e-cigarette, I'm not here to judge. I'm here to help support through that process towards completely stopping. And I do feel personally that they are decreasing that quantity of cigarettes that they're smoking because they're not lighting up every 10 minutes like 2 packs would require them to do during their awake hours. So I'm not endorsing it. Obviously, I'm saying all types of smoke inhalation is wrong. However, if that is a bridge towards stopping smoking, I'm all for it. The other thing about e-cigarettes that you always need to be careful about is you always need to, when you look at the news, monitor who's writing that article. A lot of times Marlboro is involved in that article against e-cigarettes. So there's a lot of media frenzy with that, but the most recent chest medicine article did suggest that e-cigarettes may support smoking cessation efforts. CHEST is our national organization for pulmonary critical care physicians, where they monitor all of the data that's being done on lung-related health and try to make sure that that's processed down to all of the physicians that are working under that umbrella.
I have a 2-part question. At the introduction, you said there were 2 forms of COPD. Will you repeat the first and spell it?
Chronic bronchitis and emphysema, E-M-P-H-Y-S-E-M-A. And the difference is bronchitis affects the airways, the tubing that goes to the lungs. Emphysema actually causes destruction of the sacs where air is transferred between the blood and your lungs.
Second part, will you address secondhand smoke?
Absolutely, stay away from it. It can be as hazardous as actually smoking yourself. I would say that there's a good percentage of patients in my office who have never smoked but have COPD because they lived with somebody who smoked in the house right next to them. So at the minimum, I make it a firm policy to bring that significant other into my office so I can counsel, particularly with children in the house too. It's very important. But yeah, secondhand smoke is just as bad. And there is a third part of COPD that is unrelated to smoking completely, and I just touched on that, and that's exposures to chemicals, fumes, chalk dust, things that we are very familiar with in these smaller towns that support larger factories. The woolen mill here, historically has a lot of people who develop long-term lung disease because of exposures, and back then there was no true protection, you know.
If you are a person that has a concern about this, do you have to have a doctor's consult to come to you?
We can, in general, what we try to do is allow for all self-referrals and then connect with your primary care. We've had full support of the local physicians here, and they have never been a situation where they say, no, we don't want you to see the pulmonologist.
The emphysema, is it, can you get it, like, is it hereditary?
So it's a minor part of it, and there, of the entire diagnosis of COPD is something called alpha-1 antitrypsin deficiency. And that's an enzyme that your body has a deficiency of that normally is present in everyone else that's normal with that enzyme. However, if you are deficient in it, you can develop emphysema without having ever touched a cigarette. Usually that goes hand in hand with cirrhosis of the liver, as well as a long-term genetic history that we will tease out after we talk to you about, oh, well, my father also had it and he never smoked, or my mother had it and she never smoked and she also had liver disease. Those are the things that sort of push us in that direction. However, more recently, they're actually recommending evaluating everyone essentially for alpha-1 antitrypsin deficiency to see if there may be a genetic component to it. But in general, the take-home message is to stop smoking, don't smoke. That's the key. Even if you do have that genetic component to it, there are some IV drugs that can be beneficial, but regardless, most of those patients are smoking, so my suggestion is get rid of the cigarettes first, then we'll worry about IV medications in that type of scenario. One thing that I also always make sure that is very clear is that smoking and asbestos do not mix. When you have a smoking history, you have a roughly 10 times increased risk of cancer. When you have asbestos exposure, you have a 6 to 10 times increased risk of cancer. When you've done both, you have a 60 times increased risk of cancer. And a lot of times we don't know if patients have been exposed to asbestos until it's too late.
Is there a magic age for COPD?
You see it more over the age of 40. Obviously, if there's a genetic component to it or extensive cigarette smoking, it can impact earlier. But in general, you look for it over the age of 35 to 40. Obviously, I've seen patients that smoke 4 packs a day. So that impact will manifest itself much earlier than someone who did not smoke that much.
The chronic bronchitis, what is bronchitis?
It's exactly what I was mentioning about that little hairs that live in your airways to help push mucus up. Those over the time die off, stop working because of chronic smoke exposure, preventing this mucus from coming up, which is why that mucus subsequently gets infected. You get an infection, you need antibiotics to clear that infection because it's not coming up the way it should. That's just part of it. There's also the glands that are in your airways that actually get larger because of that chronic smoke exposure, so you actually produce more mucus as you get more and more exposed to it.
But what if you are not around smoke and you don't smoke and you're not around smoke?
And you still have the bronchitis symptoms? Well, there's a component of asthma that is a whole nother disease process. And that might be what you're dealing with, and those patients have very similar symptomatology. The difference between COPD and asthma is when you do breathing tests called spirometry. And in those cases, in the majority of the situations with asthma, these patients have reversible lung disease, meaning on a good day, their pulmonary function will look completely normal. But on a bad day, they'll look like the worst smoker in the world. A person with COPD, however, good and bad days are about the same. They're still always going to have that decrease in the amount of ability to blow out in a second or their lung function that we test with regular spirometry. So the reversibility is the key. There is a component called chronic obstructive asthma where patients do have a level of irreversible damage because of chronic asthma, but that's a topic for another day.
At what stage is a person qualified to have pulmonary rehab?
Usually an FEV, and I'll have to go through the exact details, but we have an algorithm to monitor it. In general, it's based on number of exacerbations, as well as when I see a patient, you can usually, through your entire thorough evaluation, determine who would benefit from it. And that's usually more mobility, patients who need more mobility in their life, patients with recurrent exacerbations, patients with severe emphysema. A spirometric measure that we use, which is FEV1, which is lower than 50 or 60%, are definitely those that can benefit from pulmonary rehab. And part of pulmonary rehab is getting the word out that it's available now. And I think that that's very important because this is a service that's going to be of utmost value to our community.
I understand there are levels or graduations of COPD.
Yes, ma'am.
How is it a spirometer?
Yes, ma'am. There's a lot of people have come up with their own classification system, but the most traditional and most, I guess, time-honored method is the GOLD classification, G-O-L-D. And don't ask me what that stands for. Global Initiative of Obstructive Lung Disease or something like that. But it's basically Gold Stage 1, Gold Stage 2, Gold Stage 3, Gold Stage 4. And that is based on your spirometry. If you have evidence of obstruction on your pulmonary function test on spirometry, then we look at one specific number, and that's FEV1. And that's the amount of air that you can blow out in 1 second. If it's greater than 80%, it's considered Gold Stage 1. If it's 50 to 80%, it's considered Gold Stage 2. Obviously, the lower the FEV1, the worse off the patient is. If it's between 30 and 50 is Gold Stage 3, and anything less than 30 is considered severe Gold Stage 4.
Explain the relationship between the heart and the lungs and how those can sometimes collide.
Well, I think the big component of, there's a lot of ways that they can collide, but obviously if you can't breathe or your oxygen levels are running low and you need chronic oxygen therapy where you have to wear the oxygen on a chronic basis, if you're not on that therapy, then it's not just your lungs that aren't getting the oxygen, it's your body, it's your brain, it's your heart, it's your kidneys. So you are at increased risk for strokes and heart attacks. But also, and I'm trying to not get too complicated in it, but patients who have been living extended periods of time at low oxygen levels develop what we call chronic hypoxemia. And what that is your body is just used to being very low in oxygen levels, below 88%, which is unsafe. In those situations, you can actually develop what we call pulmonary hypertension, which is elevated pressures on the right side of your heart. And to simplify it, pulmonary hypertension is where you have resistance between the blood going from the right side to the left side. Blood comes from all of your body, goes into the right side of your heart. The right side of your heart pumps it into your lungs to get oxygenated. After it goes through your lungs and gets oxygenated, it comes back into the left side, which is the stronger part of your heart, and that pumps it out to the rest of the body, the nice, fresh, oxygenated blood. Then it comes all the way around your body, comes back to the right, after dropping off oxygen everywhere along its way, and is ready to go back through your lungs. If someone has chronic hypoxemia where they haven't been treated with appropriate oxygen, if they need it, then you can get more resistance of that blood going from the right to the left. And that's another sort of interplay between heart and lungs. But the most simple fact is tobacco use, COPD, difficulty with oxygen levels, all put stress on every other part of your body too, and do increase your risk of heart attacks, strokes, which is, I think, historically has always been made more important than the pulmonary side of things. So we're trying to bring pulmonary to the map.
Exposure to workplace secondhand smoke over many years ago.
Mm-hmm.
Does that change things in terms of showing up later in life?
It can, absolutely. It's a rate of decline. As we go older, every year we lose a little bit of lung function. That's just a part of growing older. However, these exposures make you lose a lot more lung function over time, which can result in COPD when you're 45 or 50 years old, because your progression of decline, just kind of a weird progression of decline, but the decline is much worse in a scenario of exposures to that type of situation. And unfortunately, 10, 20, 30 years ago, there was no such thing as masks, in factories. It was just let it blow on you. Welding can cause significant fibrosis of the lungs. And these are all things that now, fortunately, we do have regulatory standards. The coal miners in West Virginia, there's regulatory standards to that, but their incidence of COPD and black lung pneumoconiosis is very high.
You mentioned chalk dust. Does that apply to regular household dust as well? Contributing factor?
Usually household dust is going to cause more of your allergy symptoms, runny nose, runny eyes, which can make your breathing worse, but those can be treated with regular allergy-type medications, but that shouldn't cause long-term COPD. If anything, it can cause allergy-induced asthma.
How important is it to determine what's causing your COPD? In other words, I've never smoked, never been around anybody smoke, and I guess there's some other things that cause it in a person like me or something.
It's possible, and the only indication where it might impact someone at an older age would be if it's genetic, where we can actually give IV replacement therapy of those enzymes that you might be missing. However, once you have it, it's an irreversible disease. Then we got to focus on how to improve your lung function, improve your daily quality of life, decrease your number of exacerbations over the course of the year. And that's where the inhalers, the nebulizers, and pulmonary rehab all really play a factor in maintaining up-to-date immunizations as well.
So is it natural as you get older to breathe less deeply? Or?
It's not natural, I think. I think in COPDers, it's a tendency to do that because they're getting more and more short of breath because of destruction of some of the airways. So you would see more rapid, shallow breathing in those cases. But people who haven't smoked all their life, they're still taking deep breaths. And these inhalers help you do that. These combination medications that we have now, some of these medicines have very small doses of steroids, which obviously everyone's afraid of, but they're not going as much into your body. They're going into your lungs and decreasing that inflammation, decreasing that mucus production. And those inhalers really work. Cost is always a limiting side effect, limiting issue with it, but we do our best in the office to work through the insurance companies to find what works for the patient and provide samples when we can.
If you have this enzyme deficiency, my mother died at 66 of lung disease. If you don't smoke, is there anything that you can do in a preventative type way? Even if you don't smoke, is there anything else that you can do?
I think it would be worthwhile getting tested for that. It's just a blood test. However, if you don't smoke, you're already preventing it. Bottom line of it. It's essentially a smoking-related disease process. There are other outliers like the exposures, the genetics, but I think that the crucial part to remember is that when we do deal with these patients who have extensive smoking issues, that's got to be our number one effort. Stop smoking. Use the therapies we have available. Chantix is excellent. Nicotine patches, nicotine gum, Wellbutrin, psychotherapy. These are all things that we're starting to bring into our community here in Dublin as well. So I think these are all things that need to be entertained, and we try to link that with our pulmonary rehab colleagues in enforcing that when our patients are here as well.
Is it possible to
That's
have
fine.
some degree of emphysema, COPD, and asthma in the same person?
It's definitely possible. Teasing that out is very difficult sometimes because if someone has smoked 50 years of smoking, it's hard to say how much of it is asthma, how much of it is COPD. However, fortunate for us as the doctors, the treatment is pretty much the same going forward from there. It's still avoidant of the noxious smells and the triggers, but also these same inhalers, the same bronchodilators that we use, and then managing the allergy side of a patient's complaints as well.
Breathing, and you hear a wheeze, a whistle
Mm-hmm.
kind of sound.
Yes, ma'am.
Is that asthma?
And COPD. All that is mucus building up in your lungs, and the air is having trouble getting through a pipe that has now mucus in it. So you're hearing that air come across that, and you hear that high-pitched wheeze and whistle. That's why a patient would tell you, when I cough it up, I'm fine. And that's because they got rid of that mucus, and now the air can travel through that tiny tube pretty easily.
Is there a connection between sleep apnea and COPD?
There is an increased incidence of sleep apnea, and don't quote me on this one. You guys are asking some board-level questions here. There might be. I'm not going to say firmly, but sleep apnea has its own diagnostic algorithm, meaning there are certain things that we're going to ask you when we evaluate you for sleep apnea that will push us in that direction. Snoring, very sleepy during the day, someone monitoring you at night, someone waking up and noticing that you stop breathing or gasped or choked, frequent headaches in the morning, things of that nature really guide us in that direction. However, if you have COPD and you have concomitant obstructive sleep apnea, treatment of the obstructive sleep apnea will improve your breathing through the day.
I got one more.
Sure.
Do you as a pulmonologist generally listen to a person speak and have any indication, any suspicion?
You would have to have pretty severe disease for me to be able to tell when you're speaking. And part of that is we don't know how you were speaking yesterday if we met you for the first time. The change in your speaking can be noticeable, but not the first time I meet somebody and can tell right away. In general, pulmonary function test is the cornerstone. It's like an EKG for a cardiologist. You see a cardiologist, the first thing they want is an EKG. Just like that for us, the first thing we want is pulmonary function test so that we can see what strength your lungs are at right now and what response it makes when we do give you a medication to try to help relax the lung muscles.